All right, any other comments or questions of the minutes? If not, Dorothy, your motion still stand?
Yes.
We have a second by Charlie. Any question or discussion? All in favor say aye. Aye. Opposed, same sign. That motion carries. And that will take us to, and I think that's the only actual formal item we have to act on today in planning. The rest of these are going to be reports. So we will begin that process with Ms. Morgan and our construction project report update. Hello, Angie.
Hello. Good morning.
Good morning.
It's my first time at the front of this table. So we have several projects to talk about this morning. It's just a report. I don't need any action, but I did want to give you all an update on the northeast.
Angie, move that mic. No, it's not that mic. It's that little mic underneath you, the lavalier. You'll see it there. Move that away. You can actually probably move it away from you because you've got that mic.
Yes, sir.
That's what's causing that.
Is that good?
You betcha.
Okay. On the Northeast Tarrant Medical Home, we are in design. We have some concepts developed. We've gone through the first phase of approvals with schematic design. We've had meetings with nurse managers, the Northeast Advisory Council, plus the executive director of the clinic, the executive champion of the clinic. So we've been having a lot of meetings. We're finalizing the site plan right now to get that ready to run by the City of Euless for review and approval. And if y'all would like to see it, I'd be happy to bring floor plan, site plan to the next planning committee.
That would be
just
awesome.
for information.
That would be awesome.
Okay, good. So we're making progress there. The lab upgrade phase 1, which is clinical education space in the basement of the main hospital. We're going to start that project. It's ready to go. You've already approved it. We've got to wait for the Plan Ops expansion to be finished first because Plan Ops has to move into their new space in order for us to start biomeds. Inpatient pharmacy upgrade, we are nearing completion on that. We had the accessibility inspection yesterday. All the rooms have been approved by the state, and you'll remember that's the IV mixing room where we mix chemo. So all that's done. That's good news for us. The plant operation expansion is completing this month. Our schedule showed us to complete by the end of June, and we'll meet that deadline. However, the rain slowed us up a little. We were really hopeful to finish in May, but that big bunch of rain slowed us down a little. We're on target for that. We have a Texas Department of State Health Services inspection scheduled for the 17th, and then we'll move them in the next week. And oddly enough, the state has to inspect the plant operations mechanic space because it's connected to the hospital. Finally, our radiology x-ray replacement. We've already got the first general x-ray and the CT installed. The final phase of that is the second general x-ray installation, and that is pending. We're working on that and hope to have that completed this summer. Any questions?
So are all your 2015 initiated projects going to finish in 16?
Yes, sir.
Okay.
Okay,
Any
anything
other
else?
questions? All right.
Thank you all very much.
Thank you, Angie. Appreciate it. And I stand corrected. The next two items are going to be action-related items. So Diane, if you'll come up and take us through the Diabetes Collaborative, I appreciate it.
And some of y'all will remember that came to quality. This is a report that we had in quality as well, and this is just from the initiation and the effort going forward. It's part of planning and part of where we're going in the future. So that's why we wanted to bring it here and get y'all's recommendations and or approval to go forward.
Yes, thank you, sir. So good morning.
Morning.
Robert is exactly right. We presented some findings to the Quality Committee. I do want you to know that Joslin was here for several months last year. We engaged them really to do an assessment of our care for our diabetic patient population at JPS. We found the assessment to be very meaningful, and we're going to be talking about what the findings were and what we hope to do with phase 2 of that engagement. It should be noted that Joslin actually approached us several years ago about coming to help with our diabetic population, and we engaged them for the first time last year. They are interested in a long-term relationship. Also, the Patient Safety and Quality Committee, which is a multidisciplinary committee of many physicians, voted unanimously to move the Joslin proposal forward and to make a priority of caring for our diabetic patients by improving those clinical standards and orders, as you will see. So today I really want to provide you a small overview of our diabetic population, talk about what phase 1 recommendations were, and then talk about our phase 2 objectives for this proposal. When we talk about diabetes in Texas, we have a large percentage of of folks in Texas who are afflicted with diabetes. With the increase in obesity that continues today, despite many opportunities, as you know, to become healthier and eat healthier, et cetera, this number is expected to grow. Obesity is the #1 cause of type 2 diabetes in our nation. East Texas and South Texas actually have the highest rates of diabetes in Texas, but the prevalence in our region, our county, is around 8% to 8.9%. 27% of those patients have cardiovascular disease. So diabetes by itself, which is very controllable and manageable, generally has other complications that can become quite expensive when patients are not well controlled going forward. The data that you see on this slide actually comes from our Burden of Diabetes in Texas report that was produced in 2013 by our Department of State Health Services. Interestingly, the average length of stay is 6 days for a hospitalized diabetic patient, so almost a week. And as patients get older, that stay can increase by as much as 2 days for every stay. When we look at JPS overall, we currently have 29,000 patients on our EMR registry. Our electronic medical record actually collates those patients for us based on diagnoses that our physicians enter. 29,000 is a significant number. To give you an idea of the magnitude of that, we have somewhere between 100 and 115,000 patients who are regular attenders of our medical homes. So a fairly significant number of those patients are afflicted with diabetes. 45% have diabetes and pre-diabetes that are a part of our patient-centered medical home. So while 29,000 are just diabetes, there are a significant number of folks who are right on the cusp of developing diabetes based on heredity and all the other things that can go with that. In a 2-week period in May 2016, 24% of our patient discharges at JPS had a diagnosis of diabetes in the top 3 diagnoses. So that's a fairly significant number in just a 2-week time period. A few weeks ago, Dawn Ziegler brought you some statistics about readmission rates at JPS. It's the second highest readmission diagnosis for our patients. We had about 821 readmissions related to diabetes in the last 2 years. And we have multiple district projects that are focused on improving diabetes. A lot of work has been done, but we think there's a lot of work still to be done to help this patient population improve their outcomes.
For you.
Yes, sir.
The second highest readmission diagnosis, is that the primary diagnosis?
This is primary.
Okay.
Primary diagnosis.
And I had a follow-up question too, Diane.
Yes.
Does that 24% discharge, would that apply if you were to take that population measured against our connection population only?
That's everybody. That's
I
not
know,
just connection.
that's my question is, if you took just connection, is it a higher?
It is a higher, it's a very significant rate, yes,
Yeah.
sir. Pretty significant rate, yep. So when we think about Joslin, I'm not sure how much you know, I'll give you a little bit of history. Joslin was founded in 1898. It is affiliated with the Harvard Medical School. It is world-renowned, recognized around the world for their integrated care model related to diabetes. They've done a lot of work. They are renowned for their research, their clinical care, and their innovation. They see about 21,000 patients a year at that Harvard site in their own clinics. Their goal is to jointly develop and implement best practice roadmaps for diabetes across every network that they engage themselves in. As they came last fall, they did telephone interviews, they came on site, they looked at our data, they got into our medical record, and they worked with all of our stakeholders to really determine what we were doing well and what areas we needed to work on. But you're going to see from some of the findings that we've prioritized the work in inpatient as our next step. These are the recommendations. There are 2 slides. The ones that I've italicized are what we've identified as really needing to move forward in the next scope of work. And it really is to establish an inpatient diabetes oversight committee, which is multidisciplinary, so all clinical fields there, to implement standard protocols for hypoglycemia and for insulin initiation across the house. Often when patients are sick, they have some variation in their blood sugar, but we really need some standard protocols around when we initiate insulin and when we treat in different other fashions. And to establish an inpatient glucose management team so that we're not overreactive or underreactive to our patients' changes in their blood sugars. And of course, to implement baseline and outcome metrics. Since we are as a part of, prior to having Joslin here, we actually hired a full-time coordinator for the outpatient world, Kathy Robinson, who you met at the Quality Committee. And her work has really been focused on the outpatient side, although she works closely with our inpatient diabetes educator, Crystal. So in the outpatient side, we do need to improve the diabetes knowledge and care among our primary care providers and practice staff. If you remember Dr. Chaudhry, and for those of you who were here, when Dr. Chaudhry presented those findings, she said currently with 29,000 patients, most of the care for the diabetic patients happens in the outpatient with the primary care providers, and that will continue. That should happen. but we do want to increase their subject matter expertise and make sure that they have implemented standardized clinical protocols as well. Kathy is also working on the project plan for the American Diabetes Association accreditation for our medical home, so we would expect to achieve that in the next 18 to 24 months. More about that coming. These are the baseline metrics and outcomes that we would expect to see as a result of a Joslin engagement. An increase in the appropriate use of insulin, A1C admission assessment across the house. We currently do a lot of A1C measurement in the outpatient clinics as well as in our urgent care center. We're not doing it in the ED, and the ED is prepared to move that forward. We would increase protocol utilization. In some cases, we have protocols, but we don't use those like we should all the time, consistently. And so increase in that, increase in patient satisfaction, and certainly staff confidence. With those changes, we would see a decrease in our length of stay, a decrease in our readmissions, a decrease in infection rates, and a decrease in the episodes of both hyper and hypoglycemia, a decrease in insulin error rates, and certainly a decrease in use of oral hypoglycemic agents, which are not the best standard of care today.
So would an engagement, a long-term engagement with them include reports that would reflect the progress on those metrics?
Absolutely. So some of that we record today, but not in the form or fashion that is best used by our teams who are trying to impact care. They would bring tools. They have fantastic tools already developed, already working with Epic, which is our EMR, in other collaborations that they have, and so they would share all of that with us and help us to get better at that data collection and validate that data more meaningfully. Yes, sir.
Diana, we would expect to see a reduction in some of our lower limb amputation. Is that part of?
I would sure like to see that because
Yeah.
you know we have way too many,
Uh-huh.
as you know.
Yeah. So would that be one that they would look at for us?
Oh, absolutely, absolutely. We have too many folks who are losing toes and feet, and as you know, then that creates other difficult problems for those patients. So, this engagement does support our destination metrics. Certainly, it supports our patient-centered medical home. Diabetes is one of the, I hope we're going right. Diabetes is one of the metrics that we have selected. There's been a lot of work around that. For those of you who have been a part of the quality committee for a couple of years, you've seen some of that work. We've had some incremental movement in a very positive way with A1C measures in our patient population, which is great. Each of these listed DSRIP projects is carrying a measure related to diabetes in some form or fashion. So some of these are reducing these admissions to the ED, reducing ambulatory care sensitive conditions, which you'll see on other scorecards. Diabetes is one of the top reasons we admit folks to both our emergency department as well as our hospital. Care transitions is really about how we engage those patients in other interventions, if you will, as they transition inpatient to outpatient and keep them out of the ED as they go, making sure they land gently from case manager to case manager. Behavioral health, which is a project of Wayne's, is also targeted to reduce diabetic incidence of admission as well as reduce those A1Cs. Our MedStart project follows some of those patients to their home, and so on. The total potential DSRIP value, just so you know, the gross value for JPS is around $19 million, that if we meet all of those metrics, we can recover the net of that, which is a significant amount of dollars for JPS. And we're doing well in some, and others we have some challenges, particularly related to those ED admissions for inappropriate admissions. I wanted to show you how we're doing today. You don't often get to see this, and I know this is a bright, colorful slide, but the blue bars on this particular slide are when we started DSRIP, first measurements really in DY3, DSRIP year 3. The orange bars are DSRIP year 4, and the gold bars are DSRIP year 5. So what you can see, while we've moved it slightly, you can actually see a significant change for the better for our diabetic population that we're measuring in our patient-centered medical homes. So we've got patients who are actually managing their HbA1c better. They're showing up for their appointments. They're participating in education. A lot of work has been done there. So this is this one we expect to hit target on this year. And I just got the April data yesterday. It looks good as well. Blood pressure control has been a little bit more difficult. If you remember, about 45% of the patients with diabetes also have hypertension. It's a different set of medications, a different set of interventions for those patients, as you can imagine. But you can still see that we have had some progress. So in this particular chart, up is better, right? And you can see that in March, we got really close to our goal this year. We generally see a spike in the winter. We see a spike every winter. It's noted in the literature. Nobody knows why people's blood pressure goes up in the winter. We would think it would go down, but maybe folks get stir crazy and blood pressure goes up. However, we're trending 3 points below where we were last winter, which is great. So we're doing some great work with blood pressure control as well. What we'd be asking for today is to move phase 2 of the Joslin proposal forward to our finance committee and to our board of managers this month or next month. And then activate that committee and follow that project timeline, implement our work plan. This is a 9-month engagement. The cost is $250,000 for the next 9 months of the engagement. And so we would start as soon as we're able and continue that on. Certainly we have areas of risk. We do think the time is appropriate to move this engagement on. Again, Joslin came to us several years ago. We've got an engaged medical staff group who are really interested in changing this metric on the inpatient side. Our chief quality officer is very attuned to, as you know, reducing harm and improving outcomes for our patients, and he's been driving that forward. And certainly the momentum that we have with DSRIP, we think propels this forward to the next stage. And so we want to be sure that we have a good implementation, a cultural change, not just we want to implement our standard order sets, but we really want to make sure that everybody believes them and understands why. We want to get those workflows in, and we want to make this easy, which Joslin is committed to doing. So they understand JPS is different, and it's not a matter of just coming from Joslin and saying, here's what Joslin's going to do. It is a matter of working closely with our medical teams to say, let's make this work for JPS and do the best that we can. And so that is what the proposal will be about, and our ask again is to move this forward to the Finance Committee and the Board for approval.
Just to give you all a quick update, Mr. Whitman, Mr. Petty, Mr. Wynn, and myself began discussions with Joslin in April 4 years ago. Yeah. And Joslin is nationally and world renowned, but we weren't prepared at that time to just partner up with Joslin. And I give credit to staff and team that it wasn't just on the rhetoric of saying we've got a partnership with the leading diabetic and diabetes center in the nation. We tried to figure out how to make it work. And I think this is a case study to y'all as board members that says, first of all, when you have a good idea, it may be good on paper, but making it mesh and work is a different thing. And secondly, just good ideas don't really benefit our patients until we really work it out. And so I compliment Diana and team and Mr. Whitman, Mr. Petty, and Mr. Wynn for our initial talks that we had. And at first, Joslin was, we've got thousands of things and we'd like to help you. And it was a matter of trying to get that to a point where we could actually make it work.
So Diane, what is this isn't the Finance Committee obviously, but just as kind of an overall picture, what's the length of time that you see that engagement running and approximately cost either annually or collectively? Do we know yet?
So what they have proposed for the long term after phase 2, which we thought we need to do phase 2 and see how that goes before we enter, would be a long-term 5-year agreement for a co-branding at the site, building a center of excellence, Joslin, a diabetes center of excellence here at JPS. And the cost that they proposed, and we haven't even started long-term discussions about that, is $500,000 per year for that engagement.
Okay.
Now, with that, certainly they bring medical leadership, they bring physicians, et cetera. It's
Sure.
It's not just they give you a whole bunch of project work and you do it. They help recruit and hire the best and make sure that when they are gone, you can be very successful for the long term.
So that would be just, and again, understanding you haven't really negotiated the contract yet, but just put that in perspective, that's $2.5 million in cost for a potential DSRIP value of $19.8 million.
Correct.
In value. So, I'm really glad that we're doing this. It's obviously taken a long time to get it where it is, but we've always known that this potential was just dramatic for us. So I appreciate you all bringing it forward.
Pleasure.
Other questions for Diane? Okay, we will move into, we need to get a motion on that. This will be a recommendation that this be taken to the full board. Is that the?
Finance.
Taken to finance?
Yeah.
Okay, so we need a motion to recommend to finance.
Recommend it be taken to finance.
Dr. Weber's
So,
first.
second.
Dorothy is second. Any question or discussion? All in favor say aye.
Aye.
All opposed, same sign. Thank you very
And
much.
Mr. Chair, the reason that y'all are doing this and why makes sense in the grand scheme of things is there's a shared responsibility between these projects and finance. Planning really looks at what's the direction of these programs and how are we going forward, thank you very much, and how are we going forward. Then it has a finance component to it, and we want both those in sync before you go to full board. The next project is very similar, and it's also another way for us, and we talked about this with the chairman over a year ago, and that is, how do the physicians get a better voice to begin to discuss items they might want, projects, programs? We're gonna vet some of these, but also, it's a large responsibility upon you as board members to figure out the direction. We can tell you all the assets, benefits, losses, causes, but I think the direction overall from you as a board will be set by looking at things like sleep medicine services and others that will come before you. This is part of the scope of services model that we talked about some time ago in trying to funnel these through the board so that physicians have a better voice in our process, and you all have a stamp of approval or a denial of where we're going, and you may want to redirect. So that's what these two projects really have.
Yeah, it works well, and this new process, it increases transparency, it increases the opportunity for us to vet these things at a committee level, so I like it, I appreciate the change. Okay, so with that, then, we will move to our sleep medicine services. Dr. Alfaro and Ms. Sanders, welcome. Good to see you today.
Mr. Chair, may I?
Yes, sir.
Dr.
add
Alfaro, yeah, there you go.
A couple of comments, we can swing this one over there. Add just a couple of comments to Mr. Early's, so that you understand a little about what these guys have gone through before they make it to this level. We wanted to be very careful about what we brought here, so that every doctor who wants a new widget didn't land in here and taking up your time. And so, to that end, we did set up a pretty detailed process, whereby the physician and the administrative leadership in their area put together, answer a questionnaire and put together the evidence-based medicine to show, not only is there evidence-based research that makes this a good idea, but also begin the presentation of the financial argument. They take that to the chairman of their department, who then signs off on it, and once they get that signature, it comes to the medical executive committee. The medical executive committee then takes a vote to decide whether they feel as a committee if this is worthwhile pursuing. Once that's done, the ones who receive a positive vote go forward to the medical capital committee, which is the old scope of service committee. That committee is a multidisciplinary committee where we have finance, IT, and I mean the top leaders. Finance, IT, everyone sitting at the table to say, what have we missed here? You know, what other IT resources would be required here? And they give it a second go, and then they take a vote. And if it passes that, then those are the guys who will be making it to this meeting. And Dr. Alfaro, Victoria, and Kevin Hawkins put together an absolutely exceptional plan and pro forma. And so I appreciate you guys having this, and I won't go through that again. I just wanted you to understand what happens before it gets here.
No, I appreciate that, Dr. Johnson, because it wasn't that long ago when scope of services was pretty random. We weren't really sure why it got to us, how it got to us, and who was gonna be behind it, and any of that.
And
So
what
I
happened.
appreciate the structure.
Well, and Congress got nothing on us. Okay, we've got a process, just letting everybody know.
Charlie?
Chairman, I was just gonna emphasize what you said earlier. You know, you've been a finance chair, I'm the previous finance chair, and a lot of things came to finance, and finance looked at the numbers, but they didn't know the reasoning behind. And so I commend the fact that staff not only is vetted through staff, but it comes through planning, because finance looks at it truly where it fit in the budget and this, that, and the other, truly where it fits in our mission and where we're going with our, make sure, this is a great vetting process.
Yeah,
So
it
this
really
is
is.
certainly a lot better.
And
Not
this-
saying that the other didn't work, it certainly did, and we
It
certainly
didn't
acted
work.
upon recommendation. No, it
Chuck can
worked.
say
We got
that.
it through, Chuck, but anyway.
Well, and to
It's
get,
kinda
and to
like
help
widgets,
y'all,
we will consider widgets if they're needed.
to help y'all further, this is just so you all know the perspective here, this is a summary. You have the full narrative on the board portal, and you have an in-depth knowledge in the board portal, and I know that some of y'all have probably looked at that, some of you may want to go back and revisit that and go through details, but this is a summary of what we're always going to put in a more detailed narrative form for you on the portal, which will allow you to go to the nth degree of any of these projects.
It just makes a big difference, and I agree with you, Chuck, that that, you know, finance would have looked at the numbers we just said, if you're investing 2.5 million to make 19 million on the diabetic program. Those numbers sound realistic, but having heard the presentation, Dorothy and I were asking questions like, well, how many of our connection patients are in that, you know, it's probably greater than the 23%, but I mean, it really gets everyone in the process. And so I commend the way it's being done.
Big improvement. Thank you, Dr. Johnson, for your leadership in that process too. So Victoria, Dr. Alfaro, always welcome. Glad to hear from you.
Thank you, thank you. Hello all, my name is Victoria Sanders and I'm the Executive Director of Specialty Care Outpatient Services and Community Health. And it's my pleasure to introduce Dr. Alfaro. Dr. Alfaro is a professor of medicine at UNT Health Science Center, and he actually runs the sleep laboratory at UNT Health Science Center, sort of a recognized leader in sleep medicine. He's been an extraordinary partner and collaborator as we did all of the research and presentations regarding initiating sleep medicine at JPS, and he is going to get us started with some of the background and medical justification on the project.
Great. Welcome, Dr.
Great.
Alfaro.
Well, thank you. Well, I certainly appreciate you allowing us to come and speak to the committee today, and I appreciate the support that we've gotten at every level, honestly. Obviously, Victoria put a lot of work in this, so has Mr. Hawkins. We appreciate your committee, and Diana, as well as you. Appreciate you all supporting us. We've looked at sleep medicine, and we figured this is something that's really important for our patients. It's sleep apnea is a common condition. And basically what happens in sleep apnea is patients stop breathing for short periods of time when they're asleep. It has to last 10 seconds or more. And with multiple episodes like that and oxygen desaturations, that increases the risk of heart attacks, heart failure, and many other medical problems, hypertension. We also know there are many medical problems that are difficult to control. I was telling Ms. Pratchell that she gave us a segue there. Diabetes is one of them because it's more difficult to control diabetes in patients who have uncontrolled sleep apnea. Hypertension is more difficult to control in patients who have uncontrolled sleep apnea. And we have studies that demonstrate that about 1 in 2 patients with congestive heart failure left-sided heart failure have sleep apnea, and their heart failure is more difficult to control, and they have more hospitalizations until you treat their sleep apnea. Doesn't mean we're going to prevent every hospitalization or every complication, but we're hoping to kind of have an impact on the number of hospitalizations. Other conditions, atrial fibrillation, asthma, COPD, the list goes on. There is effective treatment for sleep apnea, and that's a CPAP machine, continuous positive airway pressure. Bilevel pressure gives them 2 different pressures, but what CPAP does, it just really keeps that airway open so they don't stop breathing. Now that they can breathe at night, their oxygen levels do not drop, and that really takes away a lot of the stress that's placed on the heart and other organ systems. CPAP is very effective. It's been studied. We estimate the general population, we're talking about 9, maybe 10% of males have sleep apnea, about 5% of females. In our patient population, because of comorbidities and obesity, we anticipate there's going to be about a 20% incidence of sleep apnea in that patient population. It is currently, treatment of sleep apnea and diagnosis is not a covered service. And we looked at many of the ways that are used now, and basically most patients are sent to a sleep lab to have a study done, and that's cost quite a bit. Home sleep studies, even though they're not exactly, they don't give us the exact information we get from doing a study in a sleep lab, but the information we get in that context is quite adequate in most patients. And if we identify a patient that needs a sleep study in a sleep lab, we will consider that. But generally speaking, if we do home studies, that would cut our costs significantly. And if we partner with a company that will provide them with the CPAP machine and help monitor that, and we can do an auto-titrating CPAP when they're in the home setting, that would also help us contain cost. We anticipate, and I had a patient of mine coming in the other day, and maybe he was a little more concerned than should be, but he really kind of draws the face of many of the patients that I see. He was kind of almost in tears saying, could I die in my sleep because I have severe sleep apnea? I've had this study done 10 years ago, and I can't get a CPAP machine. I can't afford one. Well, I can't tell him that's never going to happen, but and honestly, there is an increased risk of sudden death. So we do see many patients, and I think you'll probably talk a little more about how we're going to prioritize, because with saying we have 20% of our patients, we don't want this to be. That's why we really want every patient that's having a sleep study go through the sleep clinic, not only because we want to be making those decisions and helping our fellow physicians make those decisions, but also so we can try to prioritize and make sure that the service is utilized appropriately. And we're still talking about how we're going to prioritize that, which patient population we're going to target in that as our first step. And as we move forward, this is kind of going to be a moving target where we hope to improve that. There is strong data to suggest that treating sleep apnea decreases hospitalization, decreases mortality and morbidity, especially when it comes to heart attacks and strokes. And we do have a detailed plan into how we're going to implement this and start the process. I'll have Victoria kind of talk about that part.
Yes.
Is there a potential disrupt element here, maybe not in this 5-year program, but is there a precedent around the country where this could be a disrupt eligible reimbursement?
I believe there would be, I mean, you're talking about reimbursement from insurer?
Yeah, using our disrupt, in other words, create a disrupt program whereby this program could become a disrupt eligible.
You could, and I think it would look at, when you look at our homeless project and you look at some of the others, when you start looking at readmissions and you start looking at health outcomes, there certainly would be the possibility. The reason I paused is I was trying to recall if there are any at the state level, and I was thinking Houston, and I'm thinking Dallas, and I don't know of any that are current DSRIP, sort of sleep apnea, sleep center related projects, but it all relates to some of the key factors that CMS and the state is looking for. From a readmission standpoint and a reduction of cost standpoint, yes.
That actually is a excellent segue. So we pulled the data for some of the correlated sleep disordered breathing chronic conditions and total charges or cost of admissions for JPS patients over 1 calendar year, and the data is there. It's a little over, it's almost $66 million that we spent in 1 year on admissions for patients who were admitted for one of those diagnoses that Dr. Alfaro was mentioning. So the recommendation of the Sleep Medicine Services Business Plan is for JPS Health Network to purchase home sleep testing devices to be issued and utilized in the JPS Medicine Specialty Pulmonary Clinic. That's for diagnosis, and as Dr. Alfaro was mentioning, we expect that about 20% of patients that are in the JPS Medicine Pulmonary Clinic could be or need to go through the diagnosis of whether or not they have sleep disordered breathing. And then those that are diagnosed, the treatment that we're recommending is a contract with a durable medical equipment company to provide auto-titrating CPAP or BiPAP services to those patients who are diagnosed. The benefits of using a contract with the DME, so for treatment that is required, you have to go to sleep with the mask every evening. And compliance with sleeping with the mask every evening has to be measured, and there's 24-hour customer service that has to be available for patients that are undergoing treatment. DME companies have all of that available and would do it all for us. So if we contract with the DME company, that sort of minimizes the amount of incremental staff and incremental time and incremental training that we would have to, that would be an impact to the JPS Medicine Specialty Clinic. As Dr. Alfaro mentioned before, we would create within the pulmonary clinic at JPS sort of a subset called the Sleep Medicine Clinic. Dr. Alfaro and a physician assistant who's familiar with sleep medicine studies would serve as the gatekeepers for all patients that were accepted into the program. They would create criteria for acceptance and what referrals we're getting into the sleep medicine program, and they would also sort of retrospectively measure effectiveness of treatments and make recommendations on expanding the program, the number of patients that are needing services, et cetera. So basically, the plan does not require incremental staffing, but does require a little bit of a capital investment to start up initially. These are just pictures of the devices that we're.
So Victoria, before
Yes.
let's talk about that just a second.
Sure.
The DME contract, was that based on proposals? I mean, did we go out and look for best prices on that?
We absolutely did. We spent several months sort of interviewing vendors, DME companies, professionals in sleep medicine, patients, everyone, on what the best options were. The primary reason we decided to go with DME companies was one, because of the logistics of providing treatment directly to patients.
Okay.
DME companies also would offer respiratory therapists that would actually come to clinic and assist patients in sort of the education, the fitting of masks. And so after evaluating all of the options, one that we actually considered was actually opening and building a sleep laboratory. So we really considered everything on the spectrum of how to provide these services to these patients. But ultimately, contracting with the DME company proved to be both cost-effective and sort of logistically
So,
the most effective way.
On that same note then, when we decided to purchase home sleeping test, was that, I know the answer to these questions, but I just want to make a couple of points about it. I'm assuming that we weighed that against contracting with a sleep lab center that could provide those services to us, and I'm assuming that your recommendation is more effective and financially more beneficial to us.
Absolutely, that's exactly right. The cost of sending all of our patients, the 20% of patients that need to be diagnosed through a sleep lab, is cost prohibitive.
Okay.
Considering the fact that there's a home sleep testing study option available, that, as Dr. Alfaro mentioned, is effective in diagnosing sleep disordered breathing for most patients. The plan does actually overview the fact that there are some patients who wouldn't be eligible for home sleep testing. So those that don't have a stable home environment, those who have, comorbidities that really would require coming into a sleep laboratory so that, a staff member can actually watch as the patient is sleeping. And so there's actually something built into the pro forma for a small percentage of patients who wouldn't be eligible for home sleep testing, who would actually go to Dr. Alfaro's sleep laboratory at UNT.
And I say that just to say I appreciate how much vetting goes into this and the number of comparisons that you have to make, because adding a scope is not a small thing for us to do. I mean, it's a big decision. It really is, and I appreciate the work that's gone into studying this. Dr. Johnson, your process that you outlined is critical, but I think when people understand that we don't go into these scope decisions lightly, that there's a lot of comparative data that we look at, and there's a lot of process we go through to make sure we're getting the best possible, benefit for our patients at the best possible price. To me, that just reflects a much more responsible process than what we used to have when it came to going through that.
Well, there's also a big challenge in that, and Dr. Johnson sort of referred to this, there are a lot of ideas. And there are a lot of physicians that are truly committed to our patient base and truly want something to happen, but unfortunately, the numbers may not be there of patients. They may see a lot, but when you compare that to all our other patients, it may not fit the grand scheme of things, or there may be a great idea, but it's cost prohibitive. And so what we're trying to do is strike that balance between what affects the most patients and is the most cost effective for us, that we can not only justify to taxpayers, we can provide to patients.
Yeah.
And if we can strike that balance, then we're good. This one is on that realm for at least discussion. We're not gonna bring you one that's gonna affect 50 patients and cost $7 million, and we're not gonna do one that we just can't achieve. So whatever you get to this committee has at least been vetted enough to know that it's viable from a patient standpoint and the taxpayer standpoint, in our estimation. Y'all then make that final decision.
Could I ask a question on the visits that we have? Those are visits. What is your number of unduplicated patients?
So,
What page you looking at, Doug?
I'm on page 28. It's a part of their information. They gave you the clinic visit for 2014, 2015.
Gotcha.
And it's visits, and I was just asking, what is the unduplicated number of patients?
Is it not the 1346?
That's admissions.
Yeah.
No,
That's the
I'm looking at the patients, and under current state, I'm looking at 1346 patients in 2014. Is that patients or is that visits?
yes, that was the number of patients that were admitted with one of those
Okay.
sleep disordered breathing
Okay.
correlated diseases.
Yeah.
So, Ms. DeBoth, the number of patients that are in the medicine specialty pulmonary clinic, you're right, those are visits. It's a little over 2,300. And so we can provide the number of unique patients. It's probably half that.
Okay. That makes a big difference then,
Does.
so that's what I was asking on
It
that.
does.
Okay.
Yep.
All right. Yeah, some of those are reoccurring. Okay.
Yes, and follow-up care, absolutely.
Okay.
Any other questions?
No, ma'am. Thank you.
All right.
I did have another question when I was looking at the number of, I'm on page 32 now. Of
Okay.
the,
What page number?
page
32.
32 of the one where it's on the pro forma expense. I just want to make sure that when I see the first month, you would do CPAP machine, and I think your cost is 400 plus 50, so that would be 2 patients that you would be doing that on. And then, once we put them on, it's for life, right?
Yes. And once the patient receives a CPAP unit, those units are probably good for anywhere from 5 to 7 years before they need a new unit, you know, given the technology and everything. What's really nice about these units, though, is that we can monitor and, you know, because compliance is going to be a big issue. One of the things we were always concerned about is we give a patient a CPAP unit, they don't use it, really not doing them any good if it's sitting in the closet. So basically these units can be monitored, and if the patient is not using it, we want to identify why. A mask is not right, it's too tight, whatever it is, and we're hoping that we can achieve that through our DME partner, where they call the patient in and see what they can do to adjust it. But that machine is about 5 to 7 years is
About
the
5 to 7 years.
is-
So you would purchase that machine for the patient. So is it a monthly? I mean, I'm just trying to understand. I got 800.
Sure.
So that's 2 machines. That's what I'm saying.
That's right.
And so that is a one-time payment, or do I have to pay $400 the next month? Or
No, that's a great question. So the way that we devised the business plan was that we would actually contract with a DME company and pay the DME company for the
Okay.
DME company
All
to
right.
issue the CPAP device. And then the DME company would be responsible for measuring compliance and sending that information to us. And then also for tracking if there's, if the CPAP machine needs to be refreshed with
Okay.
newer technology,
All
then the
right.
DME company. So we would pay once, the DME company,
Okay.
for that CPAP machine.
That makes sense, because I was trying to figure out that, because the next month you do 60, which would be 4 more, because I was
That's
trying to
right.
see that increase in the number of patients.
Yes,
Okay.
ma'am, that's
All
right.
That's what I was trying to understand.
They maintain the equipment.
That's right.
Okay.
Just want to make sure you got your DMEs and your CPAPs and everything.
Right.
marked.
All that, you know, I'm just trying to make sure that, because I know once you add a scope, there's a lot of need out there, so I'm trying to figure out
Yeah.
how you're gonna,
It's-
that, you know, how much is it gonna take, and do we break the bank? And so, that's why I was looking, if it was a continuation, but we're buying so many. And I know the next question is that once that gate opens, we're gonna be bumping up against a whole bunch of needs.
Dr. Alfaro and I talk about that often, about what the criteria for inclusion in the program will be, and how we sort of set the boundaries for who's included and who is not. So that would be sort of an ongoing discussion, but we would have to have some referral criteria and some
Right.
boundaries, because we do think that the program could really explode.
Yeah.
Um,
Well, I was thinking about Diana's program where we were talking about the hypertension, patients that's admitted, and if they have sleep apnea, that would be an automatic monitoring over on your side that would kind of tie the, I'm thinking about hypertension, the diabetes, since it's such a high volume, because some of the others, I'm not sure how we would monitor.
We would probably prioritize some of the hospitalized patients with sleep disordered breathing, get those people through the door quicker,
Okay.
try to get them to have the home study and the CPAP unit.
Okay.
Would you be seeing them when they're inpatients?
There's probably not a need to do that. I think what would happen is once they identify patients that they feel have sleep disordered breathing, they would just schedule an appointment with the sleep clinic and have them evaluated there. If they feel that they need to be seen sooner, we would obviously have a mechanism where we could prioritize those patients.
Great.
Okay. Is there, when you look at, I'm on page 29, on your average cost per episodic care, is there maybe another diagnosis beside diabetes that you would be targeting, since COPD was one of the high readmission, look like it's admission rates? So I'm just trying to figure out how you're gonna focus in on the admission.
And I think patients with congestive heart failure, atrial fibrillation, if they're admitted for those diagnoses and have sleep apnea or have risk for sleep apnea,
Okay.
would again be prioritized. And you're right, COPD and diabetes, hypertension are those other patients
Yeah.
that we need to pay attention to.
I know you had a portion in the report showing the number of admissions that you had seen in the clinic, so,
Yes, that's right.
yeah, I saw that, and
Mhm.
it
The
was
core-
low in some of those areas,
Was
so,
low,
yeah.
surprisingly. yes.
Yeah,
And
okay,
so creating a pipeline between the our inpatient team and who's been admitted for certain diagnoses in the clinic.
Okay.
Would be another offset of this project.
Okay.
I kind of, if I might, and this is not anything negative about this particular program, but I always struggle with these kinds of questions. We could spend X more dollars on this program and create a new thing, or we could spend that X number of dollars on what we're already doing in another way, or we can keep it with the taxpayers and not spend it at all. I don't know what I'm comparing this to. It seems to me I'm being presented with a program. Do you want to do good with this program, or do you not want to do good with this program? And I don't feel like that's a good question. It's just, it seems like I don't have enough information. That these kinds of questions should be handled at a more of a kind of a board retreat to say, do we want to, where are we going? Are we just going to stumble around and every once in a while pick up a new scope of work and expand what we're doing because that's what we feel like doing, because somebody gives us a good presentation? Because there are people that can stumble in front of us and give us good presentations on situations like this all day long, and I'm faced with, do I want to do good with this work, or do I want to turn this down for some inexplicable reason that just says, well, I don't know what else is out there that I should be spending money on? Am I just lost in space?
So
or is
Warren,
that-
let me ask you a question about that, because we started this off with this incredibly detailed 4-level vetting process that these things don't even get to us anymore until they go through that process. So I don't think your question is stumbling around. I don't think that would be the terminology I would use to determine how this got to us to talk about. Now, if there's a different level of, board review, then we could talk about that. My personal feeling is I would much rather see it come to the committee level and be discussed in this level of detail rather than having to take up the entire board with it. But I would never have even, been willing to look at it and talk about it, to your point, had there not been this process that goes through this multi-level vetting now, because before you came on the board, back in the old days, and Dr. Weber and I and several, or have been around here a long time, have seen this, scope questions were entirely random questions, honestly. I mean, because it really did kind of come down to, this doctor had a great idea, and this was a necessary and good service to provide, and so let's do it. Okay? I mean, is that about right, Chuck?
That's fair.
So,
Fair statement.
now, this process is the antithesis of stumbling around. This process, to me, represents data. It represents very careful reviews and vetting at the staff level that was not the case before. And that, in fact, now it comes down to the staff saying, we've done the vetting process and we've done the prioritization. We've looked at this relative to our cost of services. We've looked at it relative to financial data and to patient impact. Now, board, planning committee, finance committee, it's a question of, is this a policy decision that is worthy of including in our scope of services at that level? And again, I think we got to give credence to that process resulting in that, as opposed to the old way that we did it. So, and again, you hadn't had the benefit of being here as long and seeing those processes, but I would ask that two things. First of all, what question do you think hasn't been answered relative to this service? But more importantly, I would ask that you consider the process in some terminology other than stumbling in front of, because it's anything but stumbling in front of, in my mind.
I'm happy to concede that the process that we're seeing, it filters out those more expensive. It gets the best idea that the medical staff has considered. That there may be 10 things they're considering, and they see, well, this one will affect 1,000 people, and this one only affect 50. So let's go with the one that's 1,000. I don't have any problem with understanding and recognizing that, and I do appreciate a stumbling around in the right direction, right? And so I don't mean that to be pejorative. I just feel that's the way I feel like it hits me. But there is a policy question of where what this hospital system is supposed to be doing and where we're supposed to be spending money as opposed to not, and where we're going to compete with the rest of the world or not. And this kind of thing is not a particularly emergency-oriented kind of thing. When I think of what we're supposed to be doing here, and again, I understand I'm still a newbie, and I will be until there's somebody else that's the newbie. But I don't think of us as addressing, as needing to, or as desirable to even say that we're going to provide every healthcare solution for every person in the county. And so that's kind of where I'm coming down on
Sure.
this.
Thank you, Mr. Chair. Mr. North, I certainly appreciate what you're saying, and I think part of it may be the overall lack of context for non-medical folks that we've done here. This is a service that I can tell you when I arrived at JPS 6 years ago, and I think I can speak for virtually every physician on our staff, we are absolutely amazed we don't offer it. This is literally almost as basic as, do we test for diabetes and give insulin? And I would ask Dr. Alfara to maybe say a few words to clear that up about where we are with this in comparison to the community state national standards of practice in medicine.
Yeah, I mean, it's a standard of practice to have sleep services covered. I mean, I again was surprised when I found that it was no longer covered. And we have multiple patients that suffer from this, and it has multiple negative outcomes. So if you look at any practice or any even discussion about sleep apnea, physicians are very surprised when I tell them that that's not a covered service, and they really can't comprehend that. And I know that I've heard many things from physicians saying, why can't we do something? And I'm telling them we are in the process of doing that, and you guys have been very supportive of that, and I certainly appreciate that. So it is a standard of care. It's like you just mentioned, it's taking care of diabetes, heart failure, any other medical
as standard
problem.
as taking care of diabetes.
The other luxury that we have is medical necessity for this board and this staff is always going to be determined by our medical team. Medical necessity as to what we should, can, and need to offer is always going to be determined by our medical group that services our patients. And one of the luxuries that all of you board members have is not seeing all the numerous other ones that probably aren't part of a scope of service that we have at least looked at to be the best determination of helping the most people. And this is not a competitive model for the industry or anything else. And I think when you start looking at programs, and I'm not here to advocate, I'm here to tell you that we have vetted very, very well what we present to you for you to make those decisions. But if you look at homeless population and others that no one else takes, if you bring in more MAs and you bring more people in to reduce your readmissions, you end up saving money. It's fact, you have less readmissions. And at some point, we're going to come to you and suggest that we need beds, 10 or 12 beds in an almost clinic-like setting so that we can take a homeless individual and instead of releasing them to the street, we can release them to a 1 or 2 day facility that will totally reduce readmissions, which is a real smart thing for our taxpayers. So it's certainly all for the debate of what we do and what we do for our patient base. But the other aspect of this that I think is so important, this organization will never advance to best practices and never advance to where we need to if we don't have a total physician engagement.
Yeah.
And we can't have a total physician engagement if we don't listen to what some of those needs are. And then be sure that we vet them in the proper way. And I, as Dr. Johnson can tell you, I've told numerous doctors, we can't do that. We can't have that. That's not in our realm. But what is in the realm, we're definitely going to bring before you. So that's what we've tried to do, is to be, as I mentioned earlier, very fair to our current patient base and very wise to our taxpayers to be able to defend why we would use that money in that way. Because we obviously take that seriously.
Trent,
And
excuse
no,
me,
go ahead.
Charlie. Robert hit upon something, again, as you know, I chair the acclaimed exec committee, and you hit physicians' engagement. And Warren, again, I think the comment about the philosophical about what's the district's mission or what's the purpose of the district, I think that may be for a retreat for the board sometime. I think those kind of philosophical questions, but this process is so much better than what we used to have. It has been vetted to here. We still got finance, and the board still has a decision to make, so there's still ample time for any additional work, whether you or any of us would want to do. But I have to tell you that this is by far a lot more transparent, and it's a lot more in-depth. And 6 years ago, I was one of those non-medical newbies, and I had trouble understanding actually what we call things we use in the hospital, and I know it takes a while, but, you know, again, this process is a true vetting and very transparent process. And today's decision just moves it, correct me, the intent, Mr. Chairman, today is just to move it to finance.
Yes, sir.
And then it will ultimately wind up on the board, so it's another 30 to 60 days
Yeah.
before this would ever be even to the board level for final presentation, so.
Well, let me ask you some questions that come up when I see something like this. As you may know, I'm involved in some education things,
Right.
and this kind of looks like sometimes we assign kids iPads and the iPads get lost. I personally know people who have had these machines and never used them. Now, we talk about, we were gonna monitor how they're used and, you know, what is there?
We actually doing that already. So we're not really bringing anything new, and that's a very good question, because we did talk about, well, we don't want these patients, first of all, we're gonna send them with a home study machine. They're gonna take that home. So I talked to people that are at JPS, that are using different devices like home EKG monitors, et cetera, and they've not had lost one yet. So that was reassuring. And I talked to Shirley Clemens, who our clinic manager, and they also issue different devices to patients to monitor and get data from them. So I was reassured that they've not lost a device, and that's good news. So hopefully giving them the home study to take home and bring that back for a download should not be an issue. So that's part one of it, is finding out if they have sleep apnea by sending them home with the device. Part two is really giving them the CPAP machine. So we deal with a lot of patients, Medicare, Medicaid, and private insurance, and insurers require us to look at, and that's, I support them in that. We want to make sure the patients are using it, otherwise we're not going to have the outcomes that we're looking for. So we monitor, and if the patient is not compliant within 90 days, is what most insurances do, they will take the device away. Basically, they will no longer pay for it, is what they say, and because of that, DME kind of takes the device away. We would use a similar model. We want to educate the patient up front, telling them this is why you're on a CPAP machine, these are the outcomes we're looking for, this is the impact it has on your heart failure, whatever it is that we're treating, and hope that they will understand why and how important it is. Most of the patients that are coming to see me, and that's the point I was going to bring up in a minute, and to support your point and your point, that physicians, just knowing that there's a sleep specialist, even though they know that we're not covering this as a scope of service, are sending me patients, and I'm seeing many patients and saying, well, why can't we do anything about this? We're sending them to you, and yet we're not doing sleep studies. So to go back one step, once we issue them the CPAP machine, we're going to partner with a DME company to monitor, and they can do that on a day-to-day basis. So if the patient doesn't use it for a week, they can tell me they haven't used it last week, and we can ask that patient to come in for an appointment. That's why we have a dedicated physician assistant who's working with me right now. Basically, she does only sleep medicine. Well, she does mainly sleep medicine for our clinic, and she runs our CPAP clinic at UNT. So we're hoping just to reintroduce that into this setting. And we'd bring the patient back and say, why are you not using it? Was the mask too big, too small? Are you forgetting? What are we doing there to try to get them to use it? If we've done everything we can and the patient remains non-compliant, they will know up front that they will not be able to keep that CPAP machine, and we would utilize that CPAP machine towards another patient. So there is very close monitoring. We're hoping also to monitor outcomes to see if this really has an impact on their CHF exacerbations, on the number of COPD attacks they have per month, quality of life measures, things of that nature. I can tell you it's bad enough when a patient comes in with their spouse and their wife tells me, I can't sleep at night because when I look at him, I wonder if he's going to die with the next breath they're not taking. And some patients go on for 30 to 60 seconds not breathing, and that can be very scary. And it's not only that, we know the impact it has on their well-being. So to answer your question, yes, we will be monitoring. We want to make sure they're compliant. If the patient's not using it, we're not going to wait for the full 90 days. We look at 30-day outcomes, and we have the capacity to say, well, they haven't used it for a whole week. They've had it for a whole week. What's going on? We need to get that corrected and fixed.
Other questions?
I know when we start looking at our scope of services, we were looking at the Medicaid program. This sleep study is covered under Medicaid.
Yes,
Am I
it is,
correct
it
on
is
that?
covered under
So-
Medicaid.
Yes,
All
ma'am.
right, okay.
It is actually fully covered, the patient doesn't pay a thing. And the Medicaid patients have the same, meet the same criteria that we would meet here. If they're not compliant, they're not using it. And I can tell you, I mean, if I look back, it doesn't happen very often, because when it does, I get really involved, and the patients become very protective. They don't want to give up their CPAP. So it's kind of one of those events that we have to deal with. It's not very often that it happens. So even in that Medicaid population, we find that they're most of them are quite compliant.
Well, I just kind of thought, Warren, that was one of our measurements. We were going to look at our scope of service to see for JPS connection, to make sure that that was the baseline. You know, it is not a very generous program. So that was one of the measurements we were going to look to make sure that at least we would be meeting Medicaid. So that was the reason I asked.
All right. We interrupted you several times. We don't, we promise not to continue to do that, but we'll allow y'all to continue.
Sure. So really, this is the last slide, and it just presents some of the assumptions that we had in the business plan. The number of, as we were talking, the number of patients per month that we're assuming that would need diagnosis and then treatment. Some of the total expenses, which are related to supplies, related to purchase of CPAP, BiPAP machines. And then there's a line item for total revenue per month, and that is sort of exclusively not for JPS Connections patients, but there's a charge associated with home sleep testing and the administration of the home sleep testing device. And so that's the revenue per month. So there's the net cost. It's almost $7,000 per month to treat 25 patients for sleep disordered breathing each month. And then the cost avoidance savings line item actually summarizes some of the research that we did on admissions, JPS admissions, for those correlated diagnoses. It's CHF, COPD, and atrial fibrillation. And so the assumption is that if we decrease hospital admissions for those correlated diagnoses by 1 admission per month, then we would save the hospital $41,000 per month. And so overall, considering the cost of implementing sleep medicine services at $7,000 per month and the savings, the downstream cost avoidance potential savings, the overall impact is a savings to JPS Health Network of almost $422,000 per year, essentially covering all of the costs of the sleep medicine services program. And so those are all of the assumptions that we sort of cooked into the pro forma. Kevin Hawkins helped us to cook all of those beautifully into our pro forma. That's in the detailed packet that you received.
Victoria, from reading through it, and then I just heard something a little different, I wanted to clarify. Was it prevention of, in your pro forma, prevention of 1 per month or 1 per quarter?
That's right. It's one of each of those 3 diagnoses, COPD, CHF,
Oh,
and atrial
per
fibrillation.
quarter, which would be
That's right.
essentially, so one of any of them per month.
That's right. That's exactly
Very
right.
good, okay.
All right, that makes a lot of sense.
So if we were still in Charlie's finance committee, I know what Charlie would say. He would say, so could an argument be made that it would be financially irresponsible not to do something like this? So I won't say that, but I think Charlie would have said something.
Chuck's already corrected me in that regard.
All right, any other questions for the,
As well as making people's lives hopefully better too, through providing service.
Yeah, we save lives.
Yeah, and let's forget that. We
Truly
do
what
have
we're in
that
business
as
to
part
do.
of what I perceive as our obligation to this community, so. Anyway, thank you.
any other questions to the presenters? Thank you all very much. We appreciate it.
Thank you
So
again.
we need a motion to recommend that this be forwarded to the finance committee.
So moved.
Motion from Dr. Weber, second from Charlie. Any question or discussion? All in favor say aye. Aye. All opposed, same sign. Motion carries. Thank you all very much. All right, that will bring us to our destination metrics presentation by Mr. Early.
Let me tell y'all what y'all are gonna see here now. You remember at the retreat that you all got this pyramid. We're doing up t-shirts for y'all, so you can wear these out in the community as well. And what we're gonna
Now we are ready.
What we're gonna do is, if you know, and you look and you refer back to that, you got the mission, you have our pillars, and you have our destination metrics. Everything under that is everything that we need to bring to you all that we feel fit those destination metrics. So what you're gonna get is an outline, and we've asked each staff member to hold their comments to 5 minutes. Only because if not, we will start running into not only time constraints, but you have to put some level of comment to these, or you'll go 30, 40 minutes per each. So what we've done is had each owner of this area represent all their other colleagues that have helped put this together. But in this case, Diana will start out and really talk about what we're doing from a school-based health center standpoint and what we're trying to meet and what that means for the destination metrics that you all have set before us.
That's correct. Thank you, sir. So if you recall, we have a destination metric around patient-centered medical home. And in the last couple of years, we've continued to progress that forward. As you know, when I first came here, it was the first project I worked on. And so in 2013, we had no designated clinics. In 2014, we began to work. In 2015, 100% of our primary clinics were designated at the highest level, which is a level 3 for NCQA. That is an accreditation that has to be applied for every 3 years. So we're already working towards that reapplication, and the elements have changed slightly. There's a lot more focus on care coordination, which is wonderful. So we definitely want to maintain our current designation as we look at the new requirements. And by the way, NCQA is the National Committee on Quality Assurance. It is a nationally recognized agency driving improvement in healthcare, and primarily known for the work it's done with the patient-centered medical home. By 2018, we'd like to get our clinics redesignated, but we've also modified this to include our school-based clinics. So they were not previously designated. Again, I think I told you at my school-based clinic presentation, NCQA doesn't generally designate school-based clinics because they're not open year-round. Ours are, so we have the opportunity to get designation there. You've sort of seen the initiatives and operational milestones for patient-centered medical home before, so I'm not going to spend any time here because you have it. I do want to highlight that we, in working on engaging patients, which can be the hardest part of a patient-centered medical home, you're all familiar with that. Patients do have to take their medicine, show up for appointments, et cetera. We had 3 health fairs recently in April at 3 of our medical homes. We had 285 patients attending. We did 89 cervical cancer screenings, which is a metric we have had some difficulty getting the results that we'd like to, but that's wonderful. We had foot exams and HbA1c tests, and we enrolled 60 patients in education. And those were so well received that we're going to continue to do those in the fall. We'll do some more. You can see some of the metrics I've already shared with you what's going on with diabetes. Certainly when we look at in any metric, we want to be sure that we've got patient, staff, and provider engagement. Sometimes that's the hardest thing to do, to keep all 3 of those elements on track. And we always want to make sure that we're not just checking off a list, but that we're actually implementing long-term transformative change. And you can see the next steps there, but we would anticipate completing our applications again in 2018. So half the locations we'd send first to see how we're doing and then move forward. Our school-based clinics, we have 20. We're really excited about that. 12 of the school districts we have a collaborative partnership with, and I did get an email this week asking if we would want to do another one. I don't have all the data on that, but I'll keep you posted on that one. Here are the initiatives that are working. One of the things we've been working to do really is to highlight and align the work that we're doing with our school districts. And so we started having an annual meeting. It was wonderful. The school districts were represented. Are we meeting your needs? And how can we work together better, which I think is the impetus for looking to continue to grow those programs. We're improving immunization rates. We have implemented our chronic care model there to make sure that our patients who have asthma and diabetes have the same kind of care as a child that they will have as an adult. And we're excited about that. So that team is currently working actively on their gap analysis for NCQA requirements. And they're very, very engaged, extremely engaged. There are complex population needs in our school-based clinics. As you know, they are generally underserved. They don't have the same kind of family support or community support, just like all of our adult patients. So we're working with all of those families. Our EMR platform is not shared across all of our pediatric facilities, so while we are all on Epic internal to JPS, our kids have to be referred for all their specialty care to Cook Children's or Dallas Children's. One of them is on Epic, so we get all that information. The other, I've heard, is working towards Epic soon, so that's great. And certainly want to retain those folks who we've trained, and then our stakeholder engagement is important, but we would anticipate submitting our school-based clinics next fall for their NCQA recognition. And that's really what we're doing for moving that destination forward. I think I stayed in 5 minutes or less.
You did?
Thank you very much. Any questions on the NCQA? All right, do we need to vote on that at all?
You
Is
do
that
not.
just a
These
report?
are
All right.
updates for y'all, to
Very
give you an
good.
idea of where we are with destination metrics.
All righty, then GME, Dr. Fowler is next. Welcome, Dr. Fowler.
So I'm here to do a short review of the destination metrics for GME. Hope everyone's doing well. So our goal in GME is to align our programs with the physician shortage in Tarrant County. And our academic pillar is to enhance the quality of patient care by developing an academic environment defined by excellent clinical care, leadership, and education and relevant research. And our strategic plan has 4 major points to it, and part of that is addressing the physician shortage through training residents and fellows. The second one is to enhance the academic presence of JPS. Our goal is to be a national leader and to inform patient care through collaborative research focused on, and we picked 3 main points for the upcoming years as quality, injury, and population health, and then to expand the capacity for peer-reviewed publications and sponsored research. And these are things that are important to us as a teaching hospital. In order to become leaders, we have to reach these goals. So what about some of the benchmarks that we're looking at? We have been looking at the percentage of doctors who stay in Tarrant County now for several years. And over the last few years, in 2013, we had about 30% of our doctors stay in Tarrant County. Our original metric was looking at DFW as a whole, but since we wanted to know how do we supply doctors to our own county, we started to look at that. So in 2013, we had 9%, but then again in 2014, we got up to 30% of our graduates staying here in Tarrant County. And 2015, another 30% staying here in Tarrant County. But the good thing about our residents is that they do stay in the state of Texas. So not only are we making sure that we have doctors to supply Tarrant County, they are also here in Texas. In 2016, we're going to look at the gap analysis report to see what are the doctors that we need for the patients at JPS. Looking at the number of residents, the type of residents that we recruit versus the population and the type of diseases that we have to take care of. And then in 2018, we want to make sure that our programs are aligned to meet the shortage for Tarrant County and also for our institution. These are some of our milestones to date. One of our metrics that we are following is our board pass rate, and our goal is 100%, knowing that the national average for most programs will range between 94 and 97%, and this is the first time taking the boards and passing it on the first attempt. And to date, we're at 97%. And this will help us to train quality doctors. We want doctors that are qualified to do their work and doctors who are doing well in their specialty. Then we're going to look at the expanded capacity for academic and clinical trials. As a teaching hospital, all programs are required to do research, and because we're a clinical entity, our goal is to do research that impacts our patient and the patient care. To date, for this academic year, we have 163 open research studies fiscal year to date and for the academic year. And then we're going to track and increase JPS-initiated clinical trials. And you might ask, why did we pull out JPS-initiated trials? We have many collaborative partners that we do research with, but we want to make sure that JPS also is recognized as a center for clinical research and trials. So our goal each year is to have, our goal for this year is 7, and we're at 5 fiscal year to date, is to have at least 7 new trials where JPS investigators initiate the trial. Now, we have 22 trials overall. We've had 34 this date, but some closed because they end. But our goal is that each year we will increase the number of trials that JPS actually bring to the institution as the primary site that's listed.
Excuse me, when you state that you are doing 22 to 34, they are using some patient data, our patient's data, but someone else is actually the primary investigator.
They're the primary site.
The primary site, okay. Is JPS name listed as a part of that when they write the report?
On some of them, yes. The next item is about creating a strategic focus for research and aligning it with quality, injury, and population health. And we're looking at how do we want to do that and where do we get started. Our initial metric for this year is to look at injury because we wanted to address some issues with patient safety and injury. And so each year, we will have a strategic plan and a goal to address some of those items. Of note, our residents are increasing their participation in quality projects, along with the institution as a whole increasing in that. We're part of a national initiative, and we've had 30-plus residents to submit projects in quality. I think last year in the Quality Fair was the largest ever that JPS had ever had. And so that's not just residents, that's all of the institutions. So our goal is to address things that are occurring right here on site. And the last is the review of GME's business plan, including the faculty agreements and the standards, and to report and recommend based on the Q4 findings. So as you know, each year we track how many faculty we had, what was the teaching that happened, how many residents we addressed, how many students we addressed. And that's not just a report for the institution, but we also do that for a national report.
Dr. Fowler, is it a legitimate benchmark or milestone to measure publications by physicians?
Yes, that's one of the metrics for the accreditation standard.
Okay.
So we report that with all of our programs. When
Okay.
we do our annual report and what we call milestones, we report that to accrediting agency. So they have to report the number of professional organizations that they're in, the number of leadership positions that they hold, the number of peer review publication, number of quality and patient safety activities. All of those are things that we report on a regular basis to our accrediting agency.
Thank you.
And then it's marked against the nation.
I see.
Our next area is our elements of risk. Doesn't necessarily mean that something is wrong in these categories, but these are things that we need to maintain. And the top one is the competition for GME slots. We want to make sure we get the top candidates because we all know that residents tend to stay where they train. And so we want to make sure those residents are staying within the state of Texas and in the DFW area. The second one is GME funding, which is a national agenda to look at how do we fund GME. We have many new medical schools, and we want to make sure that we have GME training for those students when they come out. Misdirected resources not aligned with future physician need. Again, we're going to look at our gap analysis to see what doctors we actually need in our area and in our state, and we want to make sure that we're dedicating our training to those areas. Strategic retention plan for residents in needs areas. How do we keep the residents that we need the most? One example would be geriatrics. As the population ages, how do we keep those doctors in our area? Applied research strategy to improve patient care. Again, directed research to look at the patient care and the issues that we have here on our site. So in summary, we want to initiate the Tarrant County Physician Needs Assessment and Gap Analysis for current programming, and the timeline is to have that done by December. The JPS participation in the statewide workforce needs assessment. We're collecting data not only here at JPS, but we're comparing that data to what's collected at the state level and also from the Medical Education Council about placement of students into residencies. And then implement changes in the core curriculum to include interdisciplinary learning and system-based approach. We've started that, and we want to continue and build upon that because we realize that residents or doctors do not work in isolate, and I think someone mentioned it here. Mr. Early mentioned that we have to have the doctor's feedback, but we also want to work as a team. Something new that we're thinking about doing is a quarterly forum on Talkback to discuss the challenges in medical education or the clinical learning environment, and that would help us with our accreditation and with the CLEAR visits. CLEAR stands for Clinical Learning Environment Review, and that occurs about every 18 months from our accrediting agency. They visit us and they look at what's happening on the floors. We want to align JPS program development and build retention strategy with the projected physician shortages in Tarrant County. We want to implement physician recognition through academic appointments. We've talked about that. Most of our teaching faculty have academic appointments at the universities that we partner with, but we also want to do that here to recognize those doctors who may not be eligible for those appointments at the university. And then we want to evaluate a GME leadership development program. Any questions?
Questions for Dr. Fowler?
There was a team of folks that helped in this, Dr. Fowler and others, because this is a new area for us and a tough area to have a metrics that you can actually evaluate. So I want to thank the board members for allowing us to go through this. When you start looking at, when a taxpayer says, why are you a teaching hospital and what is your value to us? I think those metrics clearly can define that as to what we're doing to address doctor shortages in our area, what we're doing to make sure that our students are passing their exams and their boards, and then what we're doing to retain those doctors in this area are metrics that we can measure. But an incredible amount of work went into this so we could come up with something that we could measure to be valuable, not just to measure, but to be valuable.
I would add that I know Tarrant County is very critical, that we would want to know Tarrant County, but I'd also think regional, because Dallas and all those areas are so close, we maybe would look at Tarrant and then look at regional. And I know we always have the state data. Those are just great stuff that you can, we should be able to follow. Tarrant County, we're not taking out anything from Tarrant County, but we do a lot Dallas-Fort Worth, and so that should be a measure that I would see that we would add. And I know you already have the state, and I think that would be a real good picture,
Yes,
showing
ma'am.
how much we do impact the entire state.
Yes, ma'am. Dallas, the city to our, yes, ma'am, we'll include that.
Well, okay. Well, I tell you that because I went to the house staff graduation, and I tell you, that was an awesome program. And as they were presenting and coming and getting their certificates and talking about, they started talking about this one, where they, what school they were recruited from, where they were going, and it was just a lot of them are staying in Dallas, and I thought, gee, and some of them was in Fort Worth, Arlington, but it was an outstanding program.
It'll give you a clear picture
Yeah.
of where we are.
Very good.
I have a comment.
Yes, sir, Dr.
And
Weber?
this is where the state of Texas gets screwed. Is graduate medical education is generally funded through Medicare in two different forms. The major slots for graduate medical education are located on the East Coast and the West Coast in far greater proportion than their physician needs. Where Texas and some other states do not get those funds because they go to places like New York, California, etc. That is a national deal that all sorts of physician organizations are fighting.
Good observation.
That's a good
So I
observation.
just
Yeah,
want to throw
Yep.
it out.
that's helpful.
I have one question on the board pass rate. I noticed at the graduation that some of those students are going into another field. They're going for a fellowship. So do they go and do state boards then, or do they wait till after they do the fellowship?
They wait until after the fellowship,
So our numbers reflect the ones that are,
that have completed.
Completed, okay.
So we have about 17% going to fellowships. So we have 17% plus a few others who have not taken the boards, and they will not take them until they finish their fellowship.
oh, okay. All right, I'm just trying to figure out how we show our board rates. That's excluding the ones with fellowship.
So the board rate calculation is based on the number who actually took the exam for the first attempt and the number passed.
Okay.
And one of the interesting thing there's, to everyone's point in the recruiting concept, and Dr. Fowler can tell me if this is still true, but when I was a program director 10 years ago, one of the I saw some peer-reviewed literature that showed that you obviously need a good residency program to train residents, but the only statistically significant factor they could find in first-time board pass rates was their National Board Medical Examiner first-time pass rates, right? Which is something that happens before you ever start residency. So if you really back it up, what we're talking about here is recruiting people to the residency to stay. You recruit your good doctors before they start their residency, if all of that still holds. But that's what we were looking at then.
True.
I have one more comment.
Yes, sir.
Setting 100% as the goal, I think is not right.
Is that unrealistic?
The national
only one
average is
reason.
only 96,
In
97.
every resident class, there will be at least one individual that stinks on written examinations.
So,
I mean, it's just a fact of life. They just don't do well, but physicians in every other way.
Well, we debated this a lot, and we felt that we would rather put it at 100 and
Oh,
explain to you
it's
why
great
we
to
Yeah,
did,
why it's not 100.
you know, why it's not 100, than say, we're gonna shoot for that. I do
I
agree with
agree
your
with you, aim
statement.
for 100, but
Yes, sir.
don't
Not gonna
expect that number to necessarily appear.
Dr. Feller, you say the national's about 96?
Yes, and it depends on the specialty. And in some of our programs, we have 100%, in other programs, we don't, you know, it's,
Right.
like you said, it's reality.
Thank you very much, Dr.
Appreciate
Fowler.
it.
We
Thank you.
appreciate it.
Thank
All right,
Sorry, I took up 5
no,
minutes.
we're good.
Somebody
We're
else.
good.
Not.
We're gonna move to our safe environment of care. Mona?
And for the, again, to preface, Mona, those of you at Quality last heard this in some greater detail, but we wanted to relate it to the destination metrics and let Mona do that.
Thank you very much, Mr. Early. Good afternoon, everyone. Mr. Chairman, as Mr. Early has mentioned, I have introduced myself to the members of the Quality Committee. I would like to take 30 seconds to introduce myself to the Planning Committee.
Please.
My name is Mona Go. I am the Executive Director for Quality at JPS Health Network. I recently celebrated my 4th month at JPS, and every day I consider it a great privilege to be able to contribute to the mission of JPS, that is transforming healthcare delivery in the communities we serve. I have been a nurse for 20 years, having served in critical care, also in clinical education, academic education. I serve as a professor at Tarrant County College, Department of Nursing, and most recently served as Assistant Vice President for Clinical Excellence with a Hospital of Corporation of America. My goal today is to be able to obtain the continued support of this august body as we work together to create a safe environment of care for our patients at JPS. I will take only 5 minutes, 4 minutes, and we get free lunch if you don't have a lot of questions. And I thank you for your kind attention.
Thank you, Mona. We appreciate it. Welcome, and we're glad you're here.
Thank you, sir. So when we look at creating a safe environment of care for our patients, we would like it to be benchmarked and reflected in the Leapfrog Hospital Safety Score. The quality pillar talks about creating a safe environment, and how do we do that? We do that by creating a culture of excellence at JPS, eliminating harm, improving our care coordination, which was very well presented by our partners in community health, and also leveraging the use of technology. And then the question is, why Leapfrog? Leapfrog serves as a very rigorous methodology for us. It is also a very practical methodology because it is being used by almost 2,000 hospitals in the country. And so therefore, when we look at our numbers and we compare ourselves, it is a safe way to benchmark ourselves and also guide us in our efforts to create a better environment for our patients at JPS. I would like to focus your attention to what our organizational efforts have been to date. Physician alignment with patient safety and quality performance metrics. Our Chief Quality Officer, Dr. Rasinia, being a physician, is very collaborative with our physician leaders, Dr. Johnson. I have been a witness to that, and I'm just so excited knowing that we have so many dedicated and engaged physicians who want to work with hospital leadership and clinical stakeholders at JPS to improve our care. Infrastructure that links quality improvement to clinical processes, clinical documentation and standardization of processes to reduce variation. I'll go into more detail later. And then creating a robust infection control program. So program development, in 2013, we started using the University Health Consortium, UHC database. There are currently 136 academic medical centers that are included in UHC. Some hospitals that you may be familiar with would be Parkland Medical Center and UT Southwestern. In 2014, we started creating a benchmarking in preparation for a Leapfrog Hospital Survey. In 2015, we submitted our first Leapfrog Hospital Survey, and we can actually forget 2015 because in 2016, we actually received the letter score of C. And what does that mean for us? What that means for us is that the efforts that we started to implement from when we first sent our survey to Leapfrog in 2015 already created the impact that we needed, a positive impact. So currently we are a C, and we are working on obtaining a B by 2018 and a letter grade of A in 2020. Just to give you a little bit of perspective, I presented this to the quality committee. The area hospitals that we have receive a letter grade of C. Only the THR hospitals receive a letter grade of A. Parkland, that received an A last year, unfortunately went down to a B. And so we know that it is a moving target, but we also know that our efforts are getting us to where we would like to go. Initiatives and operational milestones. As you can see here, the one thing that I would like to highlight is the refinement of our root cause analysis process. For a hospital as big as JPS, to me, it's really very efficient for us to be able to complete all our root cause analysis in 10 days. That means getting together all the physicians, all the clinical stakeholders in one area, and for us to be able to look at the root causes of a patient safety event. And for everyone's busy schedule, I know that we are providing the time that we need to look into these patient safety issues so that we can continuously improve. And then also our patient advisors. We have had members of our community join our committees. And to me, that is the voice of the community. That is an effort towards increased transparency on the part of JPS. And of course, Acclaim is here. And we talk about key performance indicators. And we are working on one mission. We have 6 pillars. And we have 9 destination metrics. So talk about together towards one mission. To me, that is how we are doing it when we cascade key performance quality indicators with our physician partners. Areas of risk would include, of course, time necessary to build a culture of safety. I would also like to comment that Dr. Rosinia has been very preoccupied with looking at failure. We talk about high reliability organizations a lot. I attended the National Patient Safety Foundation conference 2 weeks ago, and I was really, really relieved knowing that we were talking about the same key issues as the rest of the country. Everyone is talking about eliminating harm. Everybody is talking about patient safety. Everybody is talking about value. And JPS is talking about those same things. And so every day I am excited knowing that we are going towards better care at JPS. Adverse event reporting methodology require updating and automation. And this is where I can say that our process at JPS actually works. Before I came in, we were looking into changing our software for our event reporting. However, by collaboration, we were able to find a great solution without us having to cost the organization additional monies. So we are always reminded that we have to become very good stewards of the limited resources that are given us. And then mature infection control program, we are partnering very, very closely with our nursing division because they are the biggest workforce in our hospital. And for us to be able to leverage the relationship between nursing and our physicians, it's really going to help us get to our destination quicker. And then sustainability of improvement efforts. And very, very important would be funding support for necessary technological upgrades. Next steps, improvements in clinical documentation and concurrent physician coaching. So what we have done so far was to look at current software that allows us to do concurrent chart reviews. And with just doing that, we are actually going to impact our public reported data because before they leave JPS, we know that quality has vetted it. We know that we will put our stamp on it, that yes, it is a good reflection of the care that they receive at JPS, or no, this is not a good reflection of the care that they receive at JPS, and it is an opportunity to improve documentation. Team steps, it is strategies and tools to enhance performance and patient safety. This actually came from the military, and I'm very happy to say that, as Dr. Fowler mentioned earlier, a fifth-year resident, Dr. Fairbanks, is actually implementing and initiating what we call OR briefings, where we do timeout before the patients even get to the procedural areas. This helps increase safety because it allows us to ask questions even before the patient is in the OR area. Implement physician engagement strategies. Dr. Johnson has been a great partner in all our efforts to decrease patient harm, and then creating a task force, which we are currently already working on, and then implement Destination Zero. And I just want to highlight that for the month of April, we actually had 0 events for our COTI. We did not have urinary tract infections, and we also did not have bloodstream infections. So 0. So Destination Zero is attainable. Is it hard to attain it? Yes. Do we all need to work together to attain it? Yes. And then, of course, facility upgrades. 4 minutes. Any questions?
Mona, Pastor Emerson came towards the end of yours, so could you go back to the beginning? No, I'm kidding, I'm kidding. Yes.
Thank you, Mona. Any questions? Again, welcome. Glad to have you here. Look forward to seeing you again.
Thank you.
Thank you. All righty. Gina, I believe you're going to handle our stewardship of community resources, right?
Yes, sir.
Welcome.
You know, you have to give the young lady a lot of credit. I mean, Dr. Rossini has a lot of issues.
Moving right along.
He's not here.
No kidding. Welcome, Gina.
Hello, I'm Gina Adler. I'm the Vice President of Finance. I am Sharon Clark's counterpart. So I'm going to walk you through your operating margin destination metric. Operating margin, of course, is important as it proves that we are good stewards of our community resources that we have and the limited resources that we have. So if we are able to manage a positive margin, that's a favorable reflection of our management opportunities. As you can see from previous years, our operating margin has been positive. Back in 2013, we were at 7.5. We've had 3.1 in 14 and 15. We're at 5.1. We budgeted a 2.4% operating margin for 2016, and then we have set our long-range goal, which is multiple years for 2018 and forward. We kind of are setting at a 1.5% operating margin, which is conservative. There are a lot of risks that we have to address as we go through budgeting process and planning processes, so we do try to review that reflectively, and we can talk about those risks as we go kind of forward. We have those summarized. Our initiatives and operating margin, our operational milestones that we have set are, we kind of have had to restructure or rebuild our finance team, one of which is actually adding a CFO that is a permanent fixture and a vice president that's a permanent fixture, as well as multiple directors. And we are in the process of filling open positions in the lower level staff positions that have been vacant for some time. So we are rebuilding the facility, the finance infrastructure pretty much from ground floor up, and we are raising the standards of those individuals that we are hiring in those positions. We have reestablished our managed care relationships with our physicians and with our contractors and with our providers, so that we can establish contracts and provide access for our patients as they come into our hospitals. And we are realign those contracts so that we are connecting our physicians with our patients more aptly. So just one of the other things I'd like to emphasize is our restructuring of our policies and procedures and processes around supply chain, as we have hired a director in that position, and we are reviewing all those policies, procedures, and as we move forward and trying to improve our accessibility to supplies as our staff needs them and as our physician requests them. The risks that I referred to before are pretty significant, so we are very sensitive to those. One of which, of course, takes the legislative nature. All those programs that we have around Medicare, Medicaid, DISH, the waiver, the DISH, the UC, the DISRIP, those are unpredictable programs, and sometimes we don't really know what the impact will be to JPS until we get into that period or into that fiscal year. So we look at that with a lot of scrutiny and a lot of skepticism as we budget, so that area of our goals, we do kind of peel apart pretty much in detail. The other risks we are looking at is as healthcare is reimbursing organizations more on our patient satisfaction and our quality metrics, JPS is challenged to meet those satisfaction metrics and those quality metrics because of our physical infrastructure. We suffer a little bit at the hands of our clients or our customers based upon our physical structure, not our care or how they're treated, but more on the facade and the appearance of our physical structure. So we tend to see lower scores in our patient satisfaction because of our physical structure. Compensation is always a challenge, the last bullet point on our risk list. JPS, I guess the Dallas-Fort Worth market is a very competitive market. We live in the medical district area, and there's a lot of hospitals around in that area, and our staff has a tendency to jump to another location if they get a slight increase in compensation, or if there's a particular perk that they're interested in another location. So they will leave very quickly from our facility if we do not respond to changes in market compensation for those positions in the area. Our next steps, we have a lot to address as we go forward in the finance area to make sure that we can sustain our operating margin. We have put together, of course, a 5-year plan, and we are working with the county to continue to evaluate our RFP process. We are looking at things in our contracting and our purchasing area to make sure we're maximizing everything we can within contracts and improvements in our products. Managed care, we are focusing on that pretty strictly as we have a lot of work to be done in that area as we have pulled that back in-house, and we have begun to build an internal staff around managing our contracts with our providers. We will continue to look at revenue cycle. They are the ones who kind of make sure we capture as much cash as we can from our patients and from our insurance companies, and they are the ones who really look at cash collections and make sure we secure that information. And we'll evaluate, we are in the process of evaluating how we are managing the JPS Connection program. We have an interim person in place right now. We're going through an assessment of how we're actually running that program and how we're addressing our patients and our physicians' needs, because it's a partnership between physicians and us and our patients, and we're trying to make sure we're doing that as effectively as possible. And then we're in the process of looking at a cost accounting system, which will give us the ability to look at costs of products and costs of services and look at service line reporting. So we'll be able to tell you exactly what it costs us to provide a certain service to our patients. We have hired an executive director, and we're going through a RFP process presently, and we have a staff on board who's gathering the data so that we can hit the ground running when we're ready to do that. And then one of the things we're probably going to do pretty quick and kick off is we're going to start looking at productivity and labor standards as we put those in place, and we try to properly manage the labor staff we have, and we'll go through each area to make sure we have the appropriate staffing, where we need them and how we need them as we go forward. But these steps will help us prepare and help us address the risk and help us be able to secure as much of our operating margin as we can go forward.
Questions for Gina?
Yeah, two. One on the 5-year financial plan to support master facilities. That's outside of
JPS.
the bond program.
Yes.
Yes, sir.
Okay. But as we look at it, at the whole facilities plan, that could encompass this 5-year plan.
Correct.
Very much so. That
Yes.
is an organic statement. It is the statement that we have today, but that would have to be significantly changed depending on how things go.
Okay.
Yes.
And then my other question was, it was on the previous slide on the district. Just to remind, no,
Right there.
Just to remind me, I don't totally remember, on district, on the 1115 waiver, we're funded based on the proposal, and then we comply, am I correct?
Yes, sir.
Okay, so if we don't reach the standards where we say we are, what happens? Do we pay back? Or
We pay back,
What we do?
yes.
Do we pay it from the general fund or from Mr. Early's salary?
Early,
Mr.
early
Early's
salary,
salary.
yes.
Exactly. We're gonna hit all of them.
Pretty good incentive.
Okay.
Other
Anything else?
questions for Gina?
Thank you.
Gina, thank you very much. We appreciate it. Okay, we will probably still make our 1 o'clock goal for the board meeting. Nikki is up next, and our last presenter on our destination metrics for workplace culture and performance. Welcome, Nikki.
Good afternoon. It is a pleasure to talk with you about our leading workplace culture. I do believe that not only are we on a journey, we are achieving we're making really good strides to being a destination of choice. So many, like many of the destination metrics you've heard, there really is an art and a science to developing a leading workplace culture. And so we're going to go through a couple of the components that we've outlined in our strategic plan to help us get there. Really, it's about promoting a culture that values and respects and supports our diverse team members. We do that through our rigorously focusing on developing and improving our culture. We attract, develop, and retain, and that is primarily how we put our work in HR in those buckets. And so I'm going to talk to you a little bit about how we get there, the tools that we use to measure our engagement and our cultural improvements. And we do that by utilizing a tool from Press Ganey. As you can see by this picture, we have made great progress over the last few years. We moved to Press Ganey as our vendor of choice in our engagement process. So in 2013, we selected Press Ganey not because they had a really good tool, but also, in addition to that, it was really about the high-performing organizations that were in that database. And as you can see by this model, their model is that when you focus on the organization, the manager, and the employee domain, you will begin to have workplace engagement. We've got that. But the benefit of that is the high-performing organization. And so many of the things that you've heard today are the fruit of having an engaged workforce. And it has taken us progressively over 4 years, hard work, focus, and the work of the HR committee to get us there. And so our...
Good job, Dorothy.
How long you been with JPS?
I've been here 4 years.
That's what I thought.
I've been here 4 years. But it has been not just me, it has been my team members, it has been the board, and the focus we've had on a number of items to help our workforce move. But it's not just because of me. It is not. And so in 2016, our goal is to be at the 70th percentile, and with 2018, the 75th percentile, and hopefully beyond, and applying for the Great Places to Work Institute and or Modern Healthcare for benchmarking purposes. Some of the initiatives and operational milestones that we've achieved, there have been many. I've highlighted a few. We've achieved, as I indicated, the Press Ganey Commitment to Excellence Award, and I've talked about that on numerous occasions. We received that in a 2-year period because we moved from the 24th percentile to the 68th. We implemented another tool to help us in our retention efforts, in our selection efforts, and it's called Talent Plus, and it aids in our selection and development of talent. We've had a number of applicants throughout the last few years, but our applications are increasing. At the time we put together these slides, and that was about 2 months ago, we were approaching 16,000 applicants, and that was fiscal year to date, and we are far beyond that now. We are right around 17,000. We've launched a robust rewards and recognition program to aid in our retention efforts, launched a leadership development program, created a nursing professional development program, launched a team member development program to aid them in their professional growth and career development. What also is important for us is health and well-being. So we began to focus our benefit and wellness efforts around looking at tobacco-free workplace, breast cancer screening, and a number of other initiatives to help us in improving the health of our team members. We received the Mother-Friendly Work Environment designation, and we've received that since 2012, and so we are proud of that accomplishment as well. We've made significant improvements to our Total Rewards program. We have been fortunate in that we were able to hire a diversity officer to help us focus on our needs for diversity and inclusion and to aid us in living to our values of mutual respect. And then we defined and budgeted and implemented our annual performance incentive program at the close of 2015. There are risks inherent with not having an engaged workforce, and there are things that can impact that. One is the budget, any fluctuations, difficulty with resource allocation, the continued need for leader development and engagement, focusing our leaders, not only our frontline team members, but our leaders as well. Qualified workforce shortages can have an impact. As Gina mentioned, compensation and the need for realignment in the DFW Metroplex, even if another organization has a 25-cent move. Some of our future steps that we're planning to take, we're going to look at ways that we can focus in this competitive workplace. We're going to look at our talent management strategy, launching a new applicant tracking system.
Don't stumble with that.
And again, we compete for talent nationally, and so it's important for us to have a way to attract. We're going to look at our branding efforts as well as we begin to our RFP process for a company to help us with ad placement and creatives in our career website. We recently hosted our Diversity and Inclusion Summit in May. We are in the process of creating our strategic plan for Diversity and Inclusion 2020. Currently, we are participating in the Dallas Morning News Top Workplaces survey to see how our team members feel about JPS and to see if we are indeed a top workplace. So we're in that survey period now. We are looking to create a strong employment brand, as I mentioned, with that talent strategy. We are going to explore our strategic education initiatives and look at a career progression plan and pathways for our team members. And so these are just a few of the steps that we hope to put in place and to really execute over the next year to lead to our journey of being a leading workplace.
Questions for Nikki? Thank you, ma'am. We
Thank you.
appreciate it. We appreciate it very much.
Under 5 minutes.
And a good 4 years.
Just, and just to kind of wrap this up, I mean, these have all been packaged and presented in very concise format, and we appreciate that in the interest of time, but I also want to highlight what a great job and how much effort the staff has put into the destination metrics journey that we've been on. There have been some fantastic questions, some accountability issues raised, that really understand what these metrics are. And boy, have they done a great job, in my opinion, putting those together. So I appreciate the staff and all the work they've done in planning the metrics and the board's patience in hearing them all presented. And Robert, will this conclude? Or
It does.
Is this
We've done.
This is the end
We've
of
now
it?
gone through 2 phases of this and giving you all of the destination metrics and all the meanings behind them and how we link up to them.
Fantastic. Well, again, we appreciate the staff's effort. Fantastic presentation today. Thank you for helping us preserve our time. I'm informed of no executive session items, so with that, I will entertain a motion to adjourn. Motion from Dr. Weber, second from Reverend Emerson. Any questions? All in favor say aye.
Rex, this is still.
And if you all,